back for the third again. I'll say welcome back to the final section of the deep dive series. We've talked about the anatomy, demonstration, and reporting. I've assured us that what's it called, attached to the link of the webinar that talked on the demonstration and reporting. We will be seeing um, a live demonstration video shortly that we can use to watch to see how to do an ocular scan, as it was said. So today we'll be talking about the second tranche of common ocular pathologies, and we'll be running through them such that we will be familiar with many of them when we look at them at the point of care. Is that okay? And I told you we talked about retinal, choroidal, and vitreous pathologies yesterday, but today we'll be talking about the lens and anterior chamber pathologies, optic nerve and disc pathologies, tumors, infections and inflammatory lesions, and we're looking at miscellaneous, all other unclassified pathologies, basically, that we will be seeing. So let's talk on lens and anterior chamber pathologies, pathologies associated with the lens. One of the first things you can see with the lens is that the lens is dislocated or undergoes subluxation. This is called ectopia lenses. It is that the lens is displaced due to disruption in the fibers that hold it. So these are different levels of what's it called, of displacement, basically. Well, first of all, you have partial displacement, which is subluxation, and then you have complete displacement. The lens is completely lying away from where it supposed to be. It's now within the vitreous cavity, or it's within the anterior chamber. That is dislocation. So in subluxation is partial displacement due to zonal weakness. The lens is just decentered, but it is still around that area, um, within the pupillary area. So uh, many times it can occur post-trauma if there's a connective tissue disorder like Marfan's syndrome, some inborn errors of metabolism like homocystinuria, what's it called, severe nearsightedness, or a previous what's it called, surgery. So the person would have decreased vision, double vision, astigmatism, a lot of things like that might happen. Then also too, there could be a trembling or vibrating of the iris, which is what we call iridodonensis, basically, or shaking of the lens, which is called phacodoensis. Is that okay? There could also be elevation of the intraocular pressure. What does it look like on the ultrasound? It's so simple. You are supposed to see the lens from the demonstration just behind the iris, aligned parallel with the longitudinal axis, just parallel to that of the iris. But then, in this location, look at the lens in the vitreous cavity. Can be anywhere also to in the anterior chamber. Is that okay? So, but if there is a unilateral deviation of the lens margin, then that is what we will call subluxation. So, for example, the lens is supposed to be this way, and so the long axis, as you can see, is supposed to be parallel to that of the iris, which we are seeing here. So imagine if there is now what's it called? If this is the lens again, as you can see, and now there's a deviation in this direction, then that's subluxation, but it's still attached, probably through one of the other zonals, to this portion here. As long as it's still within that pupillary area, just behind it, then it's subluxation. So the displaced lens may be located in the anterior posterior chamber. This is located in the what's it called? In the vitreous here, or in the vitreous. So within the posterior segment. Is that okay? And then also too, there could be associated traumatic cataracts sometimes within the lens. We will talk about cataracts shortly. And there could also be associated vitreous hemorrhage if perhaps there was a blood vessel leak. So these are examples here. Dislocation, completely dislocated. There is quite a lot of hemorrhage surrounding it. So this most likely was as a result of trauma. Even the anterior chamber is looking a little bit, what's it called, has low level internal echoes inside. It's demonstrating some low level reflectivity, which might suggest blood in the anterior chamber, which we will talk about as ifema later. Likewise here. So this is lens within it, and then a lot of echoes surrounding it, most likely vitreous hemorrhage. This is a lens with internal echoes inside. This is already a lens with cataract. Is that okay? Within the posterior segment vitreous. Is that okay? Good. So this is a normal lens here. It's got some internal echoes inside, cataracts. But then look at this one, partially, what's it called, malaligned, basically. And so you can see this is in this axis this way. Let me demonstrate that for you. So this is in this axis this way, while this is in this axis this way. So that has been, what's it called, partially dislocated or undergone subluxation. Is that okay? So let's move on. Next condition is what we call an ephema. This is an accumulation of blood, as you can see, in the anterior chamber. And usually it is graded by height, that's for the ophthalmologists, and often from trauma. Is that okay? And many times it would usually be caused or be associated with what's it called, iris or ciliary tears. Blunt trauma is a risk factor. Anticoagulant, sickle cell disease, sports or accidents, or male youth, because they undergo a lot of things that make them go through a lot of trauma. So this is an example of ephema, blood in the anterior chamber. There will be pain, there will be blood vision, and there will be photophobia. Is that okay? And many times the clinical signs will show layered blood. There will be elevated intraocular pressure because what's it called? The canals that drain those things are the fluid basically and be blocked by what's it called, blood within the anterior chamber. Is that okay? So what are the ultrasound findings? When you see low, medium, or high reflectivity in a normally anechoic, in a normally anechoic, in a normally what is supposed to be an anechoic anterior chamber, then you're dealing with an ephema. So look at this, cornea is here, but then look at this internal echo inside. Plus, the lens is also having some internal echoes. This would learn is going to be most likely synonymous with a cataract. Compare that to a normal eye. Anterior chamber is anechoic, completely anechoic. So therefore, we are thinking of a hyphema here. There might be associated, what's it called, lens or iris damage. Is that okay? Um, and then you would also see echogenic materials mobile with position change in the anterior chamber sometimes. Is that okay? Internal echoes within the anterior chamber, matter a little, think I feel. Okay, basically this is following ocular trauma. So here we are seeing some blood within the vitreous, but then somewhere in front here, we are not able to appreciate, sorry, this vitreous here, we are not able to appreciate the anterior chamber. It looks quite echogenic, though this diagram does not do justice to that. But hyphema was the diagnosis. Is that okay? Good. Now let's talk on cataracts. Cataracts. We've heard a lot of cataracts. So let's talk a lot about cataracts today. So cataracts is simply the opacification of the lens. The lens is normally transparent, but then it begins to get white or it begins to change color in all various degrees. This is cataract. So opacification of the lens leading to progressive loss of vision or visual acuity is cataract. And this opacification is a product of protein denaturation. You know that thing that makes egg whites become white when it's naturally transparent? So think of cataract as that. The white becomes like the white of egg. Is that okay? Because of protein degeneration, oxidative stress, and lens fiber degeneration. So, what's the epidemiology like? Most important thing you need to know is that it is the leading cause of reversible blindness in the world, and it has no gender predilection. No male, no female, higher than the other, and it's the leading cause of reversible blindness. Risk factors: aging is the most significant. Sometimes exposure to ultraviolet light. The same way if you put egg inside water and you boil it, heat, it starts turning white. So explode, but this is not, it's not like as if you are boiling the ice, but just think of that as the reason why exposure to ultraviolet light, especially UVB, basically, will lead to increased risk for development of cataract. Is that okay? Good. Diabetes mellitus causes early onset cataracts and causes faster progression. Those who use steroids, ocular trauma, smoking or alcohol use, radiation and exposure, all of these are risk factors. And what happens is that you will see a client with a painful, gradual or progressive loss of vision. Is that okay? There could now be some glares. Is that okay? Or hypersensitivity to what's it called? To bright light, just scatters over and just triggers the person. Is that okay? There will be absence of red reflex sometimes in ophthalmoscopy. So, etiological classification. Let's talk about some of the things that can cause cataract. Basically, congenital. This is when the cataract is present at birth. Develops during childhood. Is that okay? And is often associated with some maternal infections like rubella or some genetic disorders like Down syndrome or Alport syndrome or systemic diseases. So these are the conditions where you could see congenital cataracts. The mother had one of the touches infection, which is rubella, to develop it. Could be age-related, which is the most common. Person is growing old, so the protein's nature is that okay because of biochemical changes in the lens. Traumatic cataract, often years or immediately after a blunt injury, they develop cataracts, traumatic cataracts. Is that okay? So cataracts are secondary, result from other ocular diseases like glaucoma, uveitis, or systemic disorders such as diabetic mellitus. Could be metabolic cataracts because of endocrine conditions like diabetes, galactosemia, or Wilson's disease. Then there could be drug-induced or toxic cataracts because of certain drugs like steroids. Remember we mentioned steroids before. And then radiation cataracts, for example, exposure to ultraviolet light, infrared, or ionizing radiation. So all of this could cause cataracts. Now, in order to understand where, I'm really going deep into this, but it's going to be for our benefits. In order to understand where precisely some of this deterioration and loss of transparency takes place, it's very important that we understand the anatomy of the lens. 1 minute, please. We need to understand the anatomy of the lens. Is that okay? And in describing the anatomy of the lens, the anatomists usually like using the world, the globe, to describe the lens. That is, many of the things that are being used to describe the lens, basically, are the things that you will see many times that are used to describe the Earth as a geographical body. Is that okay? So the front of the lens, which is the one in front that first contacts the light, is known as the anterior pole, like a north pole, and the back of the lens is known as the posterior pole or the south pole. The equator is the outer edge of the lens. So the if this is the north pole, the south pole, then that's the equator. Is that okay? And it is often hidden by the iris. And take note, that is the area of most cell differentiation. So it's around here that cell differentiation occurs, around here and around here. Is that okay? How does it work? What happens? Let's talk. So, first of all, the capsule that surrounds the lens, is a thin, elastic, transparent basement membrane that completely encloses the lens. Look at it here under an electron microscope. Is that okay? It provides structural integrity and serves as an attachment point for the zonular fibers. Its main structural component is what? Collagen. The next is the lens epithelium. Now, there are single layer of cells on the anterior surface, as you can see in this diagram here. They are here, just lining this layer of epithelium, lining here. But at the level of the equator, there's something about these cells. This is where they are dividing to form new lens cells. Is that okay? Now, as they divide, you observe that, look at it here, that they elongate. You can see, elongate, elongate. And then the more they elongate, they form long, thin, transparent cells arranged in concentric layers. These are the nerve fibers. Oh, sorry, lens fibers. And then the mature ones, as you can see from this point, start losing their organelles and nucleus. and then as they glues, they begin to approach the center. Is that okay? Such that the oldest of the fibers are the ones that are the center and form what we call this central lenticular nucleus. Is that okay? So again, anterior, the capsule, then anteriorly you have a layer of cuboidal cells. Towards the equator, they divide, and as they divide, they differentiate on towards the center. Once they differentiate, they elongate, lose their nucleus, and then form the lens fibers. The most compact central ones represent the older lens fibers. Then we have relevant anatomy that now talks about the nucleus and the cortex. I haven't understood this. The oldest central fibers constitute the nucleus, while the peripheral fibers form the cortex. Anterior and posterior fibers meet during development, creating Y-shaped structures. Zonular fibers. These are fine elastic ligaments extending from the ciliary body. So you are extending from the ciliary body to the lens capsule, not to the lens fibers, to the what? To the lens capsule. Is that okay? And they control lens shape by adjusting tension during accommodation. So look at it here. So now, because the most compact fibers, or the most central fibers rather, are the oldest of fibers, and this process of fiber differentiation has started since embryo, since the child was in the womb. Is that okay? We can note that we can therefore say that the nucleus is divided into embryonic, fetal, infertile, and adult parts, because all of these parts represent developmental stages and they remain permanently within the lens. The infantile, the embryonic lens fibers never go away. Is that okay? And so therefore, each named nucleus portion corresponds to the specific period of life. So the most central portions of the nucleus are the lens fibers that formed when the child was an embryo, followed by the fetus, followed by the infantile or neonatal, the infantile, followed by the adults, and then the new ones begin to form. So the anatomy of the lens was discussed so as to provide a foundational understanding of its structural components, the capsule, the epithelium, cortex, and nucleus, and to introduce the portions where cataracts occur. Based on human lens anatomy, cataracts can be divided into nuclear sclerotic, which is where you have opacification and hardening of the central portion of the crystalline lens. Is that okay? Cortical cataract, where it is the opacification of fibers surrounding the nucleus. Posterior subcapsular cataract, which is where opacities are located in the most posterior cortical layer, just directly under the lens capsule. So if we go back to that electron microscope picture, it is that this is the capsule here, and this is the most posterior lens fibers, and somewhere around here, opacification is occurring. Is that okay? So look at it, cortical cataracts around the cortex, posterior subcapsular cataracts. Is that okay? And what's it called? Nuclear sclerotic cataracts. Those three classes are the most common form of cataracts in etiology. Then there are other types: anterior subcapsular, which is opacification in the anterior cortical layer; diabetic snowflake flake cataract. This is rapidly progressive cataract, usually due to poorly controlled DM. Everything just becomes like a snowflakes, different places. Look at it here. The posterior polar cataract. Is that okay? Which is opacities in the center of the posterior capsule. Then, what's it called? Traumatic cataract, which is post-traumatic opacification, usually at the site of the injury. Congenital cataract and polychromatic cataract, which is like a rainbow-like reflection from light, rainbow-like reflections from light diffraction within the lens. Different types. No need to bother your head about that. Then also incipient cataracts, immature cataracts, mature, hypermature cataracts, of which the highest level, of which a very specific important type is of that hypermature cataract is the Morganian cataract. Is that okay? Which is like the most one of the literally the maximum guy on the spectrum of a hypermature cataract. What do you see on cataract? Regardless of the types, of which the most common three will be the nuclear sclerotic, cortical, and posterior subcapsular, what you will find many times is an echogenic lens. So you have an opaque lens material within the lens. An opaque lens material of the cataract appears as a bright area on the ultrasound. So look at the ultrasound here. The lens is supposed to be transparent, but see what you're seeing inside. You are seeing internal echogenic components within a normally transparent lens. Is that okay? The loss of lens homogeneity also too is present, and this may vary based on the cataract stage. If it is an immature cataract, low level internal echoes. If it is a mature cataract, increased echogenicity will be seen. If it's a hypermature cataract, you have a shrunken lens. Is that okay? And the capsule will appear wrinkled. And if it's a Mongolian cataract, you find a mobile dense echo floating in the nucleus. Is that okay? Within a liquefied cortex. Is that okay? So thick things. So look at these internal echoes now. And many times it might not be possible to differentiate between the types of cataracts on ultrasound. But know that once there is increased echogenicity, you are dealing with cataract. So side by side, we have a mature cataract right now and a congenital cataract. So you can see within the fetal pool while the baby's in the womb, we're already seeing cataracts there. So again, look at it again, increased echogenicity within the lens. Here it is showing thickening of the posterior wall of the lens, thickening, more thickened than usual. This is what's it called, a cataract. Take note. Also, because the echogenicity is just beneath the posterior wall. This could be a posterior subcapsular what cataract. Look at another one here also to again. So the next guy or the next condition is what we call aphakia and pseudophakia. Is that okay? Aphakia is simple. You look at the lens, there's no lens in this person's eye. Is that okay? While pseudophakia is the presence of a false or artificial lens in the eye. It, what's it called? An intraocular lens. After the natural lens has been removed. Is that okay? So, what are the risk factors? You remove a lens during the cataracts, you'll find those two or definitely would. Either of the two would occur. Then also too, sometimes primarily there might be an issue with the baby's fetal ocular development where the lens is absent. This is rare. Then there could be perinatal insults, prenatal insults, or some genetic mutation. Is that okay? The clinical features are written here. Hyperopia, iridodonensis, is that okay? Good. So ultrasound findings of aphakia. You check everywhere, you don't see the lens. How you differentiate it from subluxation, or sorry, from dislocation is that you find the lens somewhere else during dislocation. But in aphakia, absent lens echoes, you check everywhere, you don't see it. You check anterior chamber, you check posterior chamber, you check posterior segment, you check vitreous cavity, you check it within the ocular structures, you don't see it. Aphakia. Is that okay? In congenital cases, prenatal screening may show absent lens, but this is not really reliable because it's too small to be able to make that assessment. While for pseudoaphakia, there's an intraocular lens and it has a specific way it looks like. Is that okay? And let's talk about it. Normal crystalline lens echo is being replaced by a thinner and a sharper intraocular lens echo. It is usually highly reflective and flatter. Take note. So you can see highly reflective, and quite flat. Is that okay? It's a curvilinear, linear echogenic structure, sometimes curvilinear, but it's almost flat. And it is usually found at the site of the natural lens, representing the intraocular lens. You will find two distinct parallel reflective lines corresponding to the anterior and posterior surface. They might join up and down, superiorly and inferiorly. Is that okay? Now, one thing you will know, you will always see many times with this lens is that you can see repeating echoes, reverberation artifacts, always there with intraocular lens. It is very, very important in identifying it. Take note of that. So you find a flattened lens, The anterior and posterior walls join, or they join superiorly and inferiorly, and then you're finding reverberation artifacts is enough to make you know that you might be dealing with an intraocular lens here. Just ask the person, has there been a surgery before? And they tell you, yes, bam, you've picked pseudophakia. Is that okay? Yeah, so that's just it. Normally, now then also too, there might be a slightly deep anterior chamber depth when the intraocular lens is placed. Why? Because the lens is more curved than the normal intraocular lens, and so that flattening allows room for you to have more anterior posterior diameter. Is that okay? And so that's what it is. Okay, so look at it here, intraocular lens. Look at the reverberation artifacts again. Flattened, two echogenic lines here. You can see that flattened, two echogenic lines in this place, reverberation artifacts over here. Take note of that. Never forget. Optic nerve or disc pathologies. Let's talk about that one. Now, the first general thing I want you to know, which can happen for so many reasons, is the optic nerve sheath diameter increase. We've already said that the optic nerve sheath diameter should be between 3 and 5. But then when we have an increase, we have it beyond 5 mm. This enlargement first should make you think of a raised intracranial pressure in the absence of anything. Is that okay? Especially when, and then one thing you need to know is this: when the optic nerve sheath diameter is between 5 and 5.7, it can be borderline. Is that okay? Can be borderline. And then if it's borderline, it might be normal, but at the same time, it should also raise your suspicion of a raised intracranial pressure. So when there is an outright raise beyond 5.7, that you should know that there's something wrong. There are multiple conditions that are associated with increased optic nerve sheath diameter, and we'll learn that here. But what are the risk factors? Trauma, hydrocephalus, tumors, intracranial hypertension, so many things, infections, and all of that can cause increased optic nerve sheath diameter on the basis of the disease it is associated with. Symptoms, especially if there's increased intracranial pressure, there could be headache, nausea, and because of the swelling of the, or because of the increase of nerve sheath diameter, if it's as a result of what's it called, a disease which causes inflammatory changes, there could be visual obscurations, signs, papilledema, and altered consciousness. So, what do we find? Optic nerve sheath diameter greater than 5 mm in adults, greater than 4.5 in children. We've already talked about how to measure it. Is that okay? So therefore, let's take notes. First of all, 3 millimeters vertically down from the optic disc, then we measure from side to side. And like I mentioned, 5 to 5.7 mm is a gray zone, and it is usually sensitive to and can be unusually sensitive for intracranial pressure greater than 20 mm. Nevertheless, while reading in this range is more likely to be abnormal, it does not guarantee elevated ICP. Okay, so look at it here. OSNDB measured. We give 3 mm behind, and then we measure side by side. Is that okay? All right. Now, optic nerve drusen, or some people say optic disc drusen. This one, what you have is that there are calcified deposits in the optic nerve head, optic disc. It's often bilateral and asymptomatic, also called optic disc drusen, like I said, optic nerve head drusen. So what you have is calcifications around the optic nerve head. It's a very, I've seen a number of cases of drusen on an ocular scan. And so we need to talk about how it looks. It is majorly bilateral most of the times. As a matter of fact, if you look into my ultrasound diaries on my YouTube page, you'll see a case of an optic nerve drusen, and it was bilateral. What is the risk factor that we should know about? There could be a positive family history, small optic discs, vascular abnormalities. Clinical features, usually asymptomatic. There could be field defects, headaches, or blood vision. I remember that the person I did it for had a history of blood vision. Yeah. Clinical signs, elevated disc margins and mimicking papilledema. But what differentiates its ultrasound? What is it? Or no, let me say what differentiates its ultrasound. Let me say what what investigation can differentiate both the ultrasound will. Why? Because around the optic disc, there will be an elevation, but it will be more of a nodular elevation, not a plateau-shaped elevation, like or irregular, overtly irregular but plateau-shaped elevation like you see in retinoblastoma or melanoma or whatever. This one is just a small shadowing hyperechoic focus at the level of the disc. With, and like I said, with posterior acoustic shadowing. Is that okay? And this hyperechoic focus will persist on low gain. Obviously, you won't call this a retinoblastoma because first of all, it won't be in the child. Is that okay? Hyperechoic focus. So you can see this echogenic area like a stone within the optic disc. Yeah, that is optic nerve drusen. Is that okay? Next is optic neuritis, inflammation of the optic nerve. That is what it is. It often leads to demyelination of the nerve and causes acute vision loss. Incidence 1 to 5 per 1,000 and usually affects young adults 20 to 40 years. It has a strong female predilection. Risk factors, multiple sclerosis, infections, autoimmune diseases. Is that okay? And it would usually lead to unilateral vision loss and pain, difficulty visualizing colors, pain on movement. Is that okay? Yeah, and some with associated headaches. Is that okay? There could be afferent pupillary defect and disc swelling. And so, how do you see optic neuritis on the ultrasound? These findings are non-specific. First of all, it comes with a thickened optic nerve sheath diameter. Is that okay? Or a thickened optic nerve, which we would be able to see through a thickened optic nerve sheath diameter, because that takes the optic nerve and the sheath together. Also, too, would have a swollen disc. As you can see, the disc is supposed to be flat and it should follow this curvature. But then you are seeing this bump here that does not look like a drusen. That could point to that could make you suggest inflammatory changes within the optic nerve and head of the optic nerve, maybe optic neuritis. However, note this, a bump in the optic disc like this, the only thing, it's not only optic neuritis that would present with it. If there's papilloedema also, there could be elevation of the optic disc. So swollen disc and increased, what's it called? Optic nerve sheath diameter. There could also be increased sheath fluid, fine fluid there. Then Doppler may show reduced flow, basically. So look at this. So look at this bumpiness here in the optic disc. Bumpiness in the optic disc, what's it called? And increased optic nerve sheath diameter are two significant findings. Bulginess of the optic disc here are seen in what papilloedema. You can see, like I said, there's papilloedema also too. It can lead to what's it called? Now bulginess of the optic disc. Is that okay? Sorry. Okay. So let's look now properly at papilloedema. Papilloedema is optic disc swelling. Is that okay? From raised intracranial pressure. So optic neuritis is inflammatory and it can lead to raised optic what's it called? It can lead to raised optic disc. Papilloedema is due to raised intracranial pressure, not necessarily inflammatory. Is that okay? But that can also cause a swollen optic disc, as you can see, or a bulging optic disc. Is that okay? Papilloedema is optic disc swelling from raised ICP. It is not true inflammation, risking vision loss if chronic. Associated many times with idiopathic intracranial hypertension. So what happens is the optic disc swells. Optic neuritis can also present again, I say, with swollen optic disc. So these are two differentials. So you have to find out what the symptoms are to be able to know exactly which is which. Is that okay? Yeah. So risk factors, tumors, venous thrombosis, medications, there could be headache, vomiting, projectile vomiting, if there is associated ICH, intracranial pressure, transient obscuration or diplopia. Is that okay? So what are your findings? Elevated optic disc with thickened contour. Is that okay? Elevated optic disc with thickened contour. And also optic nerve sheath diameter could also be thickened. So two things, optic neuritis and papilloedema could present with increased optic nerve sheath diameter and elevation of the optic disc. Is that okay? Then the optic nerve in very severe cases can appear tortoise. That's like spaghetti, S-shaped and all. So look at the bulging optic disc. Is that okay? Bulging optic disc. Just to make a correction here, in this optic neuritis picture we saw here, this is a bulging optic disc as seen in optic neuritis. Is that okay? As seen in optic neuritis. So good. That was what I was supposed to what's it called? Show. So this is one seen in papilloedema. You can see the bulging optic disc. So optic neuritis can present with bulging optic disc, increased OSND because of inflammation. Papilloedema can also present with bulging optic disc and increased OSND, ONSD rather, because of raised intracranial pressure. Both are differentials. Intraocular orbital tumors. Now, we've talked about some of these tumors already prior in the previous lectures yesterday. We'll just revise a few of them again. So, intraocular tumors include, and this time we'll just talk about them, not dividing them into retinal choroid like we did, but they're looking at them together. There could be primary, which could be melanoma or retinoblastoma, and there could be secondary, which could be metastasis. Most commonly, tumors in the eye are metastatic in origin from other places. Nevertheless, we have primary malignancies. Primary malignancy in adults of the eye is melanoma. That in children is retinoblastoma. Melanomas and choroidal tumors are largely prevalent in adult population, while retinoblastoma is prevalent in pediatric population. So this is the epidemiology, basically. So what are the risk factors? Genetics, ultraviolet rays, these are risk factors. Clinical symptoms and signs: vision loss, leukocoria, that you see in retinoblastoma, floaters. The signs include mass, detachment, glaucoma, and all of that. Based on the condition, you will see it. So now, what are the ultrasound findings? Key things: melanoma, dome-shaped mass, as we saw here, as we see here, low reflectivity, low to medium reflectivity, usually hypoechoic or not so hypoechoic. Retinoblastoma, calcified mass. Remember yesterday? Calcified mass. Then metastatic, plateau, lumpy, bumpy, medium reflectivity. Is that okay? Those are key things. We have more details talked about in the previous lecture. Listen to it there. So this is a choroidal melanoma. You can see it's appearing hypoechoic. Is that okay? Dome shaped. Very nice. Is that okay? Look at what could this be? First of all, I'm seeing something like a plateau, regular plateau. But then, what gives it up here? Calcifications, retinoblastoma, straight up. This one, choroidal metastasis. Okay, it is the one that has the lumpy, what's it called, looking like this. Basically, this one came from a salivary gland with metastasis to the lung and choroid. Is that okay? Infectious and inflammatory lesions. Let's look at what those ones are. Endophthalmitis. This one is when there is a purulent intraocular inflammation, primarily infectious, involving the vitreous and aqueous humor. Is that okay? With progressive vitritis as the what? Hallmark. Incidence post-cataract surgery is about 0.08 to 0.68, and it is higher after intraocular lens implantation. So it is intraocular inflammation that is purulent. And many times you will see pus in the anterior chamber as you are seeing it here. Is that okay? So many times it is due to infections. So anything that can increase the risk factor of infections will cause it. For example, wound leaks, lens rupture, age greater than 50, delayed trauma presentation, immunosuppression, and invasive procedures. There will be blood vision, red eye, lid swelling, excess tears or watery eye or photophobia in these conditions. There will be decreased acuity. Is that okay? Corneal or conjunctival edema. Is that okay? retinitis, hemorrhage. So therefore, also ultrasound will not even be the first thing to tell you about this. A history will have told you about it. And what are the ultrasound findings? There will be dispersed vitreous opacities. Is that okay? The RCS, retinal choroid scleral complex, will be thickened. Is that okay? And then there could be detachments, which is a poor prognostic feature. You could find lens material. Is that okay? Internal echoes inside the lens. Is that okay? And there could be intraocular or intraorbital foreign bodies if it was as a result of a trauma that was infected because of a foreign body within the eye. Is that okay? And there, or you could, like I said, there could be dispersed vitreous opacities. Some of these vitreous opacities could be membranes, and many of them show moderate reflectivity, relatively hypoechoic to almost significantly to almost echogenic to echogenic, and they show reduced mobility if they are organized, packed up in one place. Is that okay? So take a look at all of these vitreous opacities. Terrible everywhere. And then also take a look at the thickened RCS or the chororetinal complexes. Thickened. Orbital cellulitis. This is soft tissue infection behind the septum. Is that okay? And it is often an extension of things like sinusitis and all of that, which progress into an abscess if untreated. Children have it more than adults, and it's common in Caucasians. Sinusitis, trauma, diabetes, and immunosuppression are risk factors. And here are some of the clinical features like pain, proptosis, ophthalmoplegia, fever, and lid swelling. The clinical signs could include chemosis, vision loss, if severe. Ultrasound findings, there could be preseptal edema. You find edema around the what's it called, the eyelids and conjunctiva. Is that okay? Also, too, there could be increased echogenicity of the intraorbital fat, unusual. Then another thing you'll find is intraorbital gas shadows. You are finding gas where gas shouldn't be. Is that okay? So preceptal edema will present as increased echogenicity plus or minus fluid interspersed within the areas where the eyelid is located, like cobblestone. Is that okay? Also, you could find an associated abscess if it is really that bad. And this will be hypoechoic collection, heterogeneous collection within the orbital ring. You can find some of the particles moving inside. Then also, too, if the muscles are affected, there could be muscle thickening. So here you have orbital cellulitis with abscess. Here you have a collection within the eye. Look at some of these gas shadows we are seeing as bubbles here within the eyelids here. Is that okay? Is that okay? So here you have this collection, complex collection. This is an abscess within the orbit. This is not the eye. Is that okay? Within the orbit. Also, too, you have this is the globe here, optic nerve, and you have this collection here also too. Abscesses that can be associated with orbital cellulitis. How is this not endophthalmitis? There is no affectation of there is no significant affectation of the intraocular structure yet. Is that okay? What are miscellaneous conditions? Foreign body in the eye. Foreign body is a penetrating object that enters the globe, intraocular foreign body. Is that okay? So people introducing foreign structures into the globe is into the globe itself is a intraocular foreign body. Is that okay? It poses significant risk of infection on endophthalmitis and toxic reaction depending on the nature of the of the material. It forms 18 to 40% of open globe injuries. Is that okay? Um, Males usually are 90%. Why? Because they are the ones that are usually subjected to most of the risk factors, which could be work related, especially if there are no eye protection. So clinical features: pain, vision loss, and tearing. You will usually find an entry wound, a hyphema, lens opacity, or in many cases, if it has been long-standing and not treated properly, endophthalmitis. It would usually be the cause of that. Good. And so, what do you find You might not know the object, but then you just see this solitary hyperechoic focus within the eye, especially if it's a small shard of metal or glass. Is that okay? And you could find reverberation artifacts. There could be associated retinal detachment or choroidal detachment or hemorrhage. There could be variable appearances for wood. It could be hypoechoic, whatever, depending on what it is. But you just find this focus. And if it is glass, metal, or any of those things, it will have comet tail artifacts. Is that okay? Good. So look at this. Look at this comet tail artifact here. Take a look at how this is the object, but then you're now finding small reverberations proceeding down. This is a comet tail artifact. This is a foreign body. Is that okay? An assessment, the assessment of this is intraocular foreign body. Then a differential for this will be vitreous hemorrhage. Or if you can look closely, you even see some internal echoes inside. That could be the vitreous hemorrhage that is accompanying the foreign body. Is that okay? Good. So look at, for example, look at here, like listing short areas here. In this position here, here. This is vitreous hemorrhage associated with this intraocular foreign body. Last is orbital foreign body. Now, this one, the foreign body is not inside the globe, it is inside the orbit. Whether it passes through the orbit as you are seeing here, or stays inside one of the orbits, orbital foreign body retain material within the orbit, not within the globe. Is that okay? Causes inflammation and infection. It could also has some of the risk factors like intraocular foreign bodies. Is that okay? Work and trauma related, high male predilection, because of high work absence of workplace protection, it is a risk factor. So this is an example of such here. Look at this foreign body, this wood in this man here. This was his condition. And look at what they brought out of his eyes. Look at what they saw on the MRI. Or is this on the CT and also to MRI. Risk factors, infections, and inorganic metal toxicity. Symptoms include pain, swelling, and restricted movement. Is that okay? Ultrasound finding will be an hyperechoic focus with shadowing if it's a metal. Comet tail artifacts would also be seen. There could be surrounding edema or hemorrhage. Is that okay? And then the globe integrity may also be affected. Because we are saying that it does not pass through the globe does not mean it might not affect, rupture the globe. Is that okay? So you will see that the globe integrity may be lost. So hyperechoic focus, comet tail artifacts, look at the comet tail artifact in this place, look at it running through. Is that okay? Down this way. But the thing is, it's outside the eye, which you can see here. Is that okay? This is a orbital foreign body. And so this is another one here. Look at it. This very dangerous one here, having shadows, probably metal. Is that okay? In this area, having shadows in this area. So these are intraorbital foreign bodies. You find them many times. There will be a history of workplace accidents. It will be a male. You will obviously see the entry point. So therefore, or if it's a long-term thing that the person doesn't even remember, you'll see a scar or something. A history will point to it that there's a foreign body. So you're not looking at the image on isolation. You are taking relevant history. As you will observe, a lot of these things look alike. It is very important that your history is taken to be able to make you know which differential might most likely be the case. And that is one very important thing you should know about ocular ultrasound when you are practicing in the point of care. Thank you very much for your time and for listening. I trust it has been a wonderful ride. You can look through the what's it called, the previous lectures to be able to see exactly what has been done before, to come in here and then look at the final lectures. More updates will be given consistently. You can follow the page, Ultrasound with Dr. Shokwe page. The link tree is there. Please like and subscribe to our pages or to the channel for more content. Have a beautiful evening. Cheers.